It's a really sobering thought, isn't it, that sudden cardiac death can hit young people. We hear a lot about hypertrophic cardiomyopathy, HOCM, but there's another condition we really need to get our heads around, arrhythmogenic right ventricular cardiomyopathy, ARVC.
That's right. And it's actually the second most common cause of sudden cardiac death in young individuals right after HOCM. It's significant.
Wow, second most common. Okay, so in this deep dive, we're zeroing in on ARVC, sometimes called ARVD too, right?
Yep, ARVC or ARVD, it's basically a rare inherited heart muscle problem. What happens is the normal muscle tissue in the heart's right ventricle gradually gets replaced by, well, fatty and fibrous tissue, sort of like scar tissue and fat.
Okay, so healthy pump muscle is being swapped out for filler, and why is that such a big deal?
Well, that replacement process really messes with the heart's electrical wiring. It can trigger dangerous, fast heart rhythms called ventricular arrhythmias, and that's what significantly bumps up the risk of sudden cardiac death.
Right, the electrical instability. So if you're listening and want to really understand ARVC, maybe for exams, maybe just general interest, or perhaps it affects someone you know, we're going to cover the essentials.
Exactly. We'll break down what it is, the causes, who's more at risk, how it physically affects the heart, diagnosis, treatment, and the outlook. We're working from some detailed notes here.
And the mission, as always, is to pull out the absolute must-know info, make it clear, make it memorable, cut through the noise you might find elsewhere.
Perfect. So let's nail down that definition again. ARVC. Progressive replacement of right ventricle heart muscle myocardium with fibrofatty tissue. Simple as that.
And it fits into the broader picture of cardiomyopathies, right? There are different types.
Yes, exactly. It helps to remember there are essentially 5 main categories. Hypertrophic, that's the thickened muscle one. Dilated, the enlarged floppy heart, this one. Arrhythmogenic, then restrictive where it's stiff, and then a sort of unclassified group. ARVC is firmly in that arrhythmogenic category.
Got it. So the right ventricle is the key player here. What actually triggers this replacement process? Do we know the cause?
Well, the exact trigger isn't fully nailed down, but the main driver seems to be genetics. Specifically mutations in genes that code for proteins responsible for holding heart muscle cells together.
Like the glue between the cells.
Precisely. These proteins are called desmosomal proteins. If there's a mutation, these connections can weaken and the cells can sort of detach from each other.
And that detachment leads to the fat and fibrous tissue moving in.
That seems to be the process, yes. The body tries to repair the damage, but it uses this fibrous and fatty tissue instead of healthy muscle. Now, inheritance-wise, it's usually autosomal dominant.
Meaning you only need one faulty gene copy from one parent.
Correct. Just like HOCM, often. But it's important to know sometimes it just pops up sporadic cases with no obvious family history.
Okay, so that covers the what and why. Who tends to get ARVC? Are there clear risk factors?
Yeah, there are a few key ones. Firstly, being male seems to increase the risk. It's diagnosed more often in men. Secondly, having a family history is a big one because of that autosomal dominant pattern we mentioned.
Makes sense.
And thirdly, having specific known gene mutations. We know mutations in certain desmosomal protein genes, like PKP2, DSP, and DSG2, are strongly linked. Finding one of these mutations really points towards ARVC.
PKP2, DSP, DSG2.
Yeah.
Good to have those specific names in mind. Okay, let's dig a bit deeper into how it actually unfolds in the heart muscle, the pathophysiology.
Right, so picture the right ventricle wall. Gradually, that healthy muscle gets replaced by this fibrofatty tissue. This isn't just a structural change. It has major electrical consequences.
Back to the wiring problem.
Exactly. This replacement tissue doesn't conduct electricity properly. It disrupts the normal signal pathways and creates these sort of electrical short circuits or arrhythmogenic substrates, areas prone to firing off abnormal signals.
Which leads to the dangerous arrhythmias.
Precisely. Ventricular arrhythmias. But that's not all. The wall itself gets weaker because of this infiltration. It can stretch and thin out,
Leading to
dilation. The ventricle gets bigger, maybe aneurysm formation, the little bulges in the weak wall, and ultimately the pump doesn't work as well.
Right.
Ventricular dysfunction.
And you mentioned inheritance is dominant, but it doesn't always look the same.
Correct. That's variable expression.
Yep.
Even in the same family, carrying the same mutation, one person might have severe symptoms, another might have very few. It varies a lot.
That's important. Now, you dropped a name earlier, Naxos disease. What's that connection?
Ah, yes, Naxos. It's a key association, great for exams. Naxos disease is a specific recessive variant of ARVC.
Recessive, so 2 gene copies needed.
Yes, one from each parent. And what makes Naxos distinct is the triad. You get the ARVC heart problems, plus palmoplantar keratosis, thick skin on palms and soles, and woolly hair.
Okay, Naxos triad. ARVC heart, thick hands, feet, skin, woolly hair.
Got it. That's a good memory hook.
Yeah.
So if ARVC is suspected, what else does a doctor need to rule out? The differentials.
Good question. There are overlaps with other conditions. Dilated cardiomyopathy that also involves an enlarged heart. Then there's RVOT ventricular tachycardia arrhythmias, specifically from the right ventricular outflow tract.
Okay.
Also idiopathic ventricular fibrillation, where you get VF without a clear structural cause. And sometimes myocarditis inflammation of the heart muscle can mimic some features.
So careful differentiation is needed. How common is this condition overall, the epidemiology?
It's generally considered uncommon. The figure often quoted is around 1 in 2,000 adults worldwide. Interestingly, it seems more common in certain areas, like parts of Italy and Greece.
And who gets it, typically?
It usually shows up in adolescence or early adulthood. And as we said, it's more common in males. We also know that a fair chunk of cases, maybe 30 to 50%, are familial running in families due to those desmosomal and other gene mutations.
And the critical point is its link to sudden cardiac death, especially in young adults, under 35s. It's a leading cause in that age group and contributes significantly, maybe up to 10%, of cardiovascular deaths in the under 65s. So while rare overall, its impact is serious.
Absolutely highlights the importance. How does someone with ARVC typically present? What symptoms or signs might they have?
Well, here's the tricky part. Early on, many people have no symptoms at all. And even the physical examination can be completely normal in about half of patients.
Really? Half? So it can be hidden.
Very much so. When symptoms do occur, they can include things like palpitations, feeling the heart race or skip beats, syncope, which is fainting or feeling like you're about to faint, and various arrhythmias.
Any specific arrhythmia patterns?
Ventricular ones are the main concern, but younger patients might sometimes present with atrial arrhythmias first. And tragically, sometimes the very first sign is sudden cardiac death, particularly in young, often athletic individuals.
That's terrifying. Any later stage symptoms?
Yes, if the right ventricle function gets significantly worse over time, people can develop symptoms of heart failure like shortness of breath, fatigue, swelling in the legs or abdomen. But again, signs on examination can be subtle or absent early on.
Okay, so diagnosis sounds challenging if symptoms and signs can be minimal. What tests are key?
It definitely is a challenge. It requires putting multiple pieces together. The ECG, the electrocardiogram, is usually the first step. We look for specific clues.
Like what?
Inverted T waves in the right-sided chest leads, V1 to V3, are common. But the really characteristic finding, the one to remember, is the Epsilon wave.
Epsilon wave. What is that exactly?
It's a small positive deflection, like a little blip, seen right at the end of the QRS complex, again, often in those right precordial leads. It represents delayed electrical activation in parts of the right ventricle. It's quite specific when present.
Epsilon wave, got it. Anything else on ECG?
You might also see ventricular arrhythmias, and typically they have a left bundle branch block, or LBBB morphology. That pattern tells you the arrhythmia is starting in the right ventricle.
Okay, ECG clues. T-wave inversion, epsilon waves, LBBB pattern VT. What next? Imaging.
Absolutely. Echocardiogram, the heart ultrasound, is vital. It can show if the right ventricle is enlarged, if parts of its wall aren't moving properly, that's hypokinesis or ekinesis, that the wall looks thin, or if there are those aneurysm bulges.
So echo gives a good look at structure and function.
Yes, but cardiac MRI often gives even more detail. MRI is fantastic for actually seeing the fibrofatty replacement within the muscle. It can quantify RV size and function very accurately, detect aneurysms, show fatty infiltration, fibrosis. It's a really powerful tool for ARVC.
MRI for seeing the actual tissue change. And genetics.
Genetic testing is increasingly important. Finding one of those known ARVC-associated mutations, like in PKP2, can help confirm the diagnosis, especially in tricky cases. Plus, it's crucial for screening family members.
Right, identifying others at risk. Any other tests?
Routine blood tests are usually done: FBC, kidney, liver function, maybe inflammatory markers, cardiac enzymes if there's chest pain, but they aren't specific for ARVC. A chest X-ray might show an enlarged heart, but often looks normal. Sometimes more invasive tests like RV angiography were used, but MRI has largely replaced that.
So it's really about combining ECG findings, imaging like echo and especially MRI, Clinical picture, family history, and sometimes genetics.
Exactly. There are actually formal diagnostic criteria, the task force criteria, that weigh up all these different factors, major and minor criteria to reach a diagnosis.
Yeah.
No single test tells the whole story.
Makes sense. Okay, let's talk treatment. How is ARVC managed once diagnosed?
Management is really individualized. It depends heavily on the patient's risk profile, symptoms, and how severe the RV dysfunction is.
What if the heart function is already quite poor?
If there's significant RV dysfunction causing heart failure symptoms, then standard heart failure medications are the first line, things like ACE inhibitors, beta blockers, diuretics. In really advanced refractory cases, cardiac transplantation might be considered.
And what about someone diagnosed but with no symptoms?
For asymptomatic patients, especially if they have certain risk factors, beta blockers might still be prescribed. The main goal here is preventing dangerous arrhythmias and sudden death.
Which brings us to high-risk patients.
Yes. For anyone deemed high risk, maybe they've already survived a cardiac arrest, had documented sustained VT, severe RV dysfunction or certain genetic mutations, an implantable cardioverter defibrillator, or ICD, is absolutely crucial.
That's the device that can shock the heart back to normal rhythm.
Exactly. It monitors the heart rhythm constantly and delivers a life-saving shock if a dangerous arrhythmia like VT or VF occurs. It's a key part of preventing sudden cardiac death in these patients.
What about lifestyle?
Hugely important. Patients are strongly advised to avoid intense competitive sports and very strenuous physical activity. These can be triggers for arrhythmias in ARVC.
Makes sense. Any medication specifically for the arrhythmias?
Yes, anti-arrhythmic drugs can be used to try and suppress ventricular arrhythmias and reduce symptoms like palpitations. Sotalol is one that's commonly used, but others like amiodarone might be considered too.
We mentioned ICDs for high-risk prevention. Any other procedures?
Radiofrequency ablation is an option. This is a catheter procedure where an electrophysiologist maps the inside of the heart to find the source of the arrhythmias, those arrhythmogenic substrates we talked about, and uses heat to destroy them.
Can that cure it?
It's usually not a cure, but it can significantly reduce how often someone gets VT, lessening the need for ICD shocks and improving quality of life. And again, for end-stage disease, transplantation is the ultimate option.
So lots of options, but it really needs that tailored approach and shared decision-making.
Absolutely. Between the patient, the cardiologist, the electrophysiologist. It's a team effort based on individual risk and preferences.
What's the long-term outlook like for someone with ARVC? The prognosis?
It's really variable. It depends so much on the initial severity, how early it's diagnosed, how well it's managed, and crucially, whether they experience life-threatening arrhythmias.
Sudden death is the main worry.
It remains the major concern, especially in younger people before diagnosis or without adequate protection like an ICD. That's why risk stratification and ICD implantation in high-risk individuals are so vital.
Does good management help the outlook?
Definitely. Regular cardiology follow-up, sticking to the treatment plan medications, ICD checks, lifestyle advice, all contribute to better outcomes. But we have to remember it's typically a progressive condition.
Meaning it gets worse over time.
Generally, yes. The fibrofatty replacement can continue, RV function can decline further, and sometimes the left ventricle can also become involved later on, leading to biventricular failure. But the rate of progression varies hugely between people.
Any idea of overall survival rates?
It's hard to give exact figures because it varies so much, but some estimates put the annual mortality rate at around 1 to 3%, even with modern management, which highlights it's still a serious condition requiring lifelong care.
Understood. And what are the main complications we should be aware of?
The big ones stem directly from the disease process. Number one is the increased risk of ventricular arrhythmias VT and VF. That's the direct pathway to sudden cardiac death.
Which is why it's a leading cause in the young.
Exactly. Second is the progressive heart muscle damage itself. That ongoing fibrofatty replacement leads to worsening RV dysfunction, potential dilation and aneurysms, and eventually can cause right-sided or even biventricular heart failure with all its associated problems. Fluid retention, breathlessness, reduced exercise capacity.
Okay, so arrhythmias and progressive pump failure are the key complications. Right, let's try and boil this down. What are the absolute must-remember key takeaways for ARVC?
Okay, top points. One, it's primarily genetic, often autosomal dominant, affecting those cell adhesion proteins. Two, it mainly targets the right ventricle, replacing muscle with fibrofatty tissue. Three, this leads to a high risk of ventricular arrhythmias and sudden cardiac death, particularly in young people.
Got it. And diagnostically?
Key diagnostic clues. Remember the Epsilon wave on the ECG, plus T wave inversions and LB morphology VT. And cardiac MRI is crucial for visualizing that fibrofatty replacement.
And management.
Risk stratification is key. ICDs are life-saving for high-risk individuals. Lifestyle changes, particularly avoiding intense sports, are vital. Anti-arrhythmics and ablation can help manage arrhythmias.
Excellent summary. Thinking about all this, especially the genetic basis and the variability, it raises some interesting questions, doesn't it?
Definitely.
Like, how might advances in genetic screening change how we approach conditions like ARVC? Could we see much earlier diagnosis, maybe even preventative strategies in the future based on genetic risk?
That's a huge area of research. Or another thought, given how differently ARVC progresses in different people, what are the biggest hurdles we face in getting better at predicting who will have a milder course versus who will progress rapidly? Predicting individual outcomes is still really challenging.
Lots to think about there.
Indeed. And look, if you're studying for exams or just want to dive deeper into this and other medical topics with really focused revision notes, definitely check out pastthemsra.com. There's also free MSRA.com for, well, free resources too.
Great resources. Understanding these conditions, even the rarer ones like ARVC, is so important. Thanks for joining us on this deep dive.